Good morning, Michelle. This is Victor.
Good morning, Victor. How are you?
Good. Okay. I was checking on my phone. Now I'm getting on my computer. We'll be there shortly.
Good, good. Good morning, everyone. As you're logging in, getting your sound and hopefully some video online, please take a moment in the chat box to include your facility name and the individuals who are participating today, so that we have an accurate registration for our program and CME credits. Again, as everyone's logging on, please take a moment in the chat box to put the name of your facility and each individual who's participating so that we have an accurate attendance and CME credits. Karen Vleck is the administrative assistant working with me on the project, but I believe she will not be able to log on this morning. So I want to be sure that we adequately capture the chat box for her. Okay, and one last time before we begin, please log into the chat box. I see a few more folks logging in here. I'll give you just a minute. Okay. And again, one more time, if everyone would put the name of your facility and the individuals participating in the chat box. Okay, well, good morning, everyone. And today's Project Echo session will be on the topic of community spread and community prevalence of COVID virus and how that impacts our work in the skilled nursing facility, both our staff and our residents. I'm going to share my screen and begin. Give me 1 second to get to the PowerPoint presentation for today. And this will be uploaded into our session as well. And let me go to slideshow. Okay. So our agenda for today will be a discussion of community spread, as I said, and how it impacts our work in the nursing facilities. And then we will circle back to our discussion about vaccine processes because it's so front and center of everything we do. And then we have a QI perspective on using high visibility flow charting as we do our quality improvement planning. So with that, I'm going to start right with community prevalence of COVID. And this is a screenshot that I took this morning from the CDC's website, where I go every day looking at the community prevalence in the country, and then I go locally so that as we're planning how we're responding, both with understanding our health department and advocating for when the amount of testing we're doing with staff and our residents and long stay patients, and discussing policies for visitation. These are the data that are most important for us. So these are the data on prevalence of new cases. And no matter what we talk about with vaccine and treatments for early COVID, these are the data that will make the difference in when we can reduce our routine testing for staff and for residents, and when we can have open visitation policies again for our nursing facilities. So these are the data on number of new cases and going back to the beginning of the pandemic. And this is January 22nd of 2020. Yes, soon we'll be at 1 year worth of data, and up through most recent data that the CDC can report. So these are real-time data. These are number of cases. And so it helps us understand the spread and helps us understand when we were beginning to see a relaxation in our visitation policies and less frequent testing in the spring or late, I shouldn't say spring, but beginning into the summer. But these are national data. What's relevant for these data, these are what the federal government's looking at, but our state governments and our county health departments are looking at these data specific to their own regions as we're seeing, because we know our policies for nursing home visitation and frequency of testing are dictated by our state departments of health and our local departments of health. But these are the data that we use. I also use our Johns Hopkins website. We too, here at Hopkins, have these type of tracking data in real time. And this morning I went and we can track by region. So for this session this morning, I decided to track our Pennsylvania demographics and new cases per 100,000. And so I prefer looking at the data of new cases per 100,000. Because it does give us that understanding. We'll see more cases in an area where there's a higher density of population. So it kind of levels the playing field for us across the state. And here are your data as of this morning for the last 7 days of new COVID cases. So I'd like to ask the group to unmute us and share with me whether you find these data for your area surprising or not surprising. And let's talk about how what data you're using to look at prevalence in your community. So who'd like to start the discussion? I'll leave this up for a moment so we can look at the data, but I will ask that we begin to have a discussion about this type of prevalence data in the community.
This is Tara Winter from Chapel Manor. We actually, Genesis Healthcare provides us weekly emails with the community transmission with not only our community, but the surrounding communities as well.
That's great. And what format? You said it's email communication?
Yes.
How are the data presented?
I'm trying now. It's actually like on it shows like a scale of, green, yellow, red, and then it, talks about testing, doing twice a week testing versus potentially 1 week testing, and then it shows the percentages for your county as well as the percentages surrounding our surrounding counties.
That's great. So how do they define red, green, yellow? Based on the new cases per 100,000?
So that information's there, and then just I believe the red is, I think it's over 10%, where you have to do the most amount of testing and so forth. I'm trying to remember off the top of my head.
No, you're doing great. That's terrific. Yeah. And that's exactly, and that's a corporate, that email comes to you corporately?
Yes, so it's kind of all tied into one for us so that we can, obviously we're required to check that weekly for testing requirements and so forth. So it's kind of one nice little package together for the facility and gives you a good picture about how you should be proceeding.
That's great. So you have a standardized approach. Everybody in the corporation is seeing it. Anybody know to whom that email goes? What type of staffing receive that email?
I believe it's center leadership, which would include the administrator, the director of nursing, the infection control nurse. I believe it includes definitely those primary leaders.
Sure. Can I ask how that type of information then gets distributed throughout the facility to your family members, to some of your residents, to your frontline staff?
I know that we kind of have a stand-up meeting every morning with all the facility department heads,
Mhm.
and we go over that information with testing requirements, what's being changed, what's not,
Mhm.
and so forth.
That's great. Good. Anyone else want to talk about how you receive this information and how you use this information?
Uh, at Crestview Center, we actually bring that up. I bring that up every week on our family Zoom calls.
Yeah.
And I use that as a talking point as far as some of the restrictions that we are having to impose based off of, the incident rate and the positivity rate.
Mhm.
I also compare week over week, so that way they kind of see if we're moving in the right direction, and it kind of puts people at ease, and it also kind of lets them know like where we are from a, I do talk, like Tara said, I will bring up other counties, so they're aware of where we are in relation to those things. But the nice thing about that report is it really does tell you everything that you need to know from a, from a visitation perspective to a testing cadence. And I share that with our families. And as far as the staff are concerned, that does go out to center leadership. I do forward it to my management team. And we do talk about that in our morning AM stand up when that comes out. So we are sharing that information.
Terrific. What type of format of presenting these type of data do you think, or have you found is most impactful?
Well, a lot of it really does come down to a lot of people, get hung up on positivity rate
Mm-hmm.
because it's a flashy number and it's a percentage.
Yeah.
But I find that the incident rate really is more telling
Mm-hmm.
because it really does kind of tell you based off of 100,000 people or 10,000 people, how many people are actually sick with COVID at that exact time frame.
Mm-hmm.
So it takes a little bit for more people to understand that statistic, but I find that actually has more power where you can say like, hey, if you're in a room with 100 people, you can assume that 4 people in that room are positive with COVID.
On
So
average.
you should be more careful with that, and that's why what that number means.
That's a great way to share that with the community, um, and helps us all remember the importance of the social distancing.
Mm-hmm.
So that's fantastic.
And I keep saying when that number keeps going down, that means things that we're doing are actually having an impact. So we really want to see that number drive down, and we've been fortunate that our positivity number is kind of there, but that incident rate's the one that I really focus on with people.
Yeah, yeah. That's the number I try to emphasize, makes a difference in our visitation policies, and as you mentioned, our testing policies as well. And the number that really drives our visitation policies will be hospitalizations. And from a federal point of view and a state and local point of view, it's overwhelming our healthcare system. Emergency rooms, hospitals, skilled nursing facilities, with cases. We are different now than we were in the spring because we have so much other healthcare that's happening. We all had the luxury in the spring of having low census. Individuals who could avoid us did, and elective surgeries were canceled. And we're now seeing the impact of continuing healthcare and some of the delays in healthcare. I had the unfortunate experience of having a patient with metastatic cancer come because of delays in diagnosis over the spring when elective testing was not available to her. So I think we all have those examples of where that's not happening now. And our healthcare system now also with adequate PPE is not canceling elective surgeries. And so the data I just showed, we also then look from a health system point of view at hospitalizations. And those same sites have hospitalization rates too, and ICU. And we look at those daily as well. Who else has an experience of being responsible for these data in your facility and how you're using these data? And if anyone is having trouble with their microphones, feel free to use our chat box to add comments as well. I'm going to go back to sharing my screen again and going to the PowerPoint presentation. And oops. In our Johns Hopkins site, I particularly like that because we can then track state level, as I just mentioned, and I showed you Pennsylvania. But in addition, we have our real-time hospital data for our regions. So again, very important as we're looking at our transitions in care and looking at our data. I understand we've had greater than 95% occupancy in our ICUs across our health system this past week. And as I'm being called as medical director of our post-acute care facilities to accept new patients, perhaps patients I would not accept so within the next few days, trying to figure out how we can serve them given our census. So, any other discussion before I go to the next topic and how we're using these prevalence data or incidence data, meaning new data? I do want to just stop for a moment and go to another section of my computer where I have in real time some data up in front of us. So let me just bring that down and go in here. Oops. Here's the CDC tracker I was looking at. Let me actually go. Here's the Pennsylvania data we were looking at. And not only is it number of new cases, it also, I find the CDC, or this is our Hopkins data. We're also looking at the different populations and cases and death rates. We, in the area that we serve, we are seeing higher incidence of COVID infection in our Latinx population and our African American population, with higher death rates in our African American population. And we're trying to understand some of that. Some of it is we're finding delays in presentation. So individuals arriving sicker to our emergency rooms and trying to understand the spread. And as we're beginning to roll out vaccinations, we've also begun to advocate for high-risk populations and controlling spread by understanding where new cases are occurring, beginning to target vaccine. So we're seeing a lot of discussion nationally as well in how vaccine is being rolled out and locally. And these type of data are informing health department and state leadership. And we're seeing some changes in vaccine rollout as a result, trying to get vaccine to those most likely to get COVID that would then spread it to vulnerable populations as well. So lots of good public health discussions on these data. So new cases, cases that result in deaths and morbidity, and hospitalization. So all those data are so important as that come to us, and so that we can better understand our testing strategies and mandates, and our visitation, which is so important to us. And then also understanding the importance of vaccine. Anyone else want to share their experience of using community spread data and talking about community spread and how you talk about it in your facility with your staff, your residents, and your families? I don't see Erin on the call today, but I believe I saw Adam on the call from a corporate level. There you are. Any comments you'd like to make on the use of community spread data in Genesis facilities?
I think Tara kind of, described our process pretty well. We do base a lot of our admissions and testing off of the guidance surrounding the data that we push out, which we also use CMS data for other nursing homes just to kind of trend. So there's a group of IT analysts that kind of help us put all that together. And then on our weekly leadership calls, our chief medical officer goes over these numbers to let us know kind of where we stand. But, to Tara's point, the individual leaders in the center are the ones who make the decisions, taking into account what else they have to worry about as far as state regulations, local health department regulations, and those things. So we provide national guidance, gives them a framework to work in, but they make the ultimate decisions and work with a group of folks at the regional level. So RVPs and clinical operators that work in that region will help them make those decisions as far as admissions and banning admissions and how else to use the data to limit the spread and to limit their risk during that time. But also, you know, we have hospital partners that we serve that need a place for the residents to go, so we have to take that into account. And then also we have families that, you know, have loved ones in our facilities, and we have to take that into account and communicate on the other end of that. So, but Tara did a good job of describing what our process is.
It's great. It's great. Yeah, the importance of the partnerships of hospitals and skilled nursing facilities, and being certain that both are shored up with respect to having adequate bed availability, including for your observation units when accepting new residents. Are you, anyone else like to talk about that issue in particular? Are you continuing to see where the observation units are needed? Because in fact, new admissions to your facility, negative on arrival to the hospital, and then perhaps even negative before coming to the facility. Anyone have the experience of then having a positive during the observation stay? Well, I'll tell you that this past week we have here within my own post-acute care unit, and we're also seeing it now that we've begun doing weekly testing of inpatients across Johns Hopkins Medicine inpatient facilities. We estimate about 5% of hospitalized patients negative on admission are having positive testing. I'll share with you some of those tests are believed to be false positives, and we're beginning to do a more sophisticated testing on positives. And it has to do with the type of testing. It's called replication cycles. So the way the test becomes positive is you identify the RNA of the virus in our PCR testing, and that requires multiple cycles of replication of the RNA before that virus can be detected. And the number of cycles in the laboratory to get to that positive is now something that we're beginning to look at. Now, not a standard across all of our testing, but when they're, as we're trying to understand where these tests can leave us short clinically, we are seeing some cases where it takes a number of replication cycles before there's a positive. And some of our researchers are beginning to weigh in and say, we're going to deem this type of result to be a false positive. But clinically, we are still managing those individuals as if they were COVID positive in terms of isolation and the quarantining for 10 days. But majority of the positives that we are seeing are real. And we're recognizing that individuals become acutely ill with worsening of their chronic conditions, COPD, heart failure, diabetes management. We've even had acute appendicitis that then a few days later is a positive. And it reminds us of what we talked about a few weeks ago with respect to the testing. And we know that the testing leaves us short in the first 3 days after exposure to the virus. And we expect an individual to be negative the day they're exposed to the virus, but anticipate their positive being on average day 4 or 5. But may well be negative day 1, 2, and 3, and yet they're presenting to our hospital with their chronic illness worsening, and we're managing those, and we get that negative test. And then as their virus experience progresses during their illness, they become positive, sometimes symptomatic with new COVID symptoms and sometimes not. So our hospital teams are beginning to recognize that and having a change in practice. And in part, this is due to the higher prevalence of the virus in the community. So people with chronic illnesses are more exposed now and more likely to have both their chronic illness worsened and potentially, just like with influenza, where the flu can worsen a chronic illness, so can COVID. So that's what we're beginning to see now with this new higher prevalence. So it isn't just more community spread with young people. The young people are bringing it to the older people with chronic illnesses, and they're presenting to the hospitals with their chronic illness, and then they're presenting to the skilled nursing facility for post-acute rehab. And between the hospital and the SNF, we're now seeing these new cases. I know Genesis has done a great job of having your observation units stand up, and you have routine protocols with new admissions. Last week we talked about how facilities have reconfigured the environment to have appropriate places for those observation units, and now we all recognize how much they're needed. Adam, thanks for sharing in the chat box your comments about having the centers with dedicated COVID centers across the country for Genesis that have that ability then to be a pressure relief valve for your hospitals and your healthcare systems, and keeping the healthcare system shored up with adequate ICU beds, adequate ED throughput, and adequate hospital beds is part of the reason. Will help the policies that relate to visitations for our SNFs and also the practical day-to-day operations of small businesses, restaurants, gyms, everything else that we do. All of that's impacted by the spread in the community, and what an important role we have in our healthcare system, and particularly our skilled nursing facilities. So great work happening in how we're using these data, understanding these data, and a change in the data from the spring till now, and how we're using these data. Anyone else want to make a comment on community spread, community prevalence data, hospital data, and how it impacts what we do day to day?
Mike Miller from Mitchell Center. Each Monday we get a great tool from Genesis that two-part form shows our community incident rate for the previous week by day, and also graphs the positivity rate. And so we hand that out at the morning meeting on Monday, which really sets the cadence for our testing. Right now we're at 10.5, and that requires us to test staff universally twice during the course of the week. On Monday we had a special family Zoom meeting for our second upcoming COVID vaccination clinic, and we put that two-part community transmission risk spread rate on the screen, the shared screen, with all the responsible parties and family members around that call. And we do that on our weekly family Zoom call as well, to, in essence, show family where the positivity rate has gone, and the fact that we're really stressing that our residents only go out for medically necessary appointments, and the reason why is because of the high rate of positivity spread in the community. So it's a great tool that Genesis provides us with every Monday as center executive directors that we could take to our department managers and also share on Zoom calls with family members.
Great summary. Thank you. Thank you, Michael. That's a great segue into a little more discussion of vaccine. But before we do so, the leaders at Johns Hopkins Medicine are advocating at both a state for Maryland, but also a national, in getting monoclonal antibody therapies into skilled nursing facilities and assisted livings, because also our assisted livings are having another surge in cases, and very much wanting to use these treatments in these community settings so that individuals can be treated and not advance their illness and require hospitalization. We've identified two barriers. One, three. One, getting medical providers to order the therapy, and so we're doing a lot of education in medical directors and SNFs and assisted living on the benefits of the therapy. Our second barrier is actually having the therapy available when the medical provider orders it. And third is having the staffing to administer. So having the licensed nursing to administer and observe for that 1 hour infusion. And the leadership at Hopkins asked me on these calls today to get some feedback from the skilled nursing facility frontline staff on the calls, as well as the leadership staff on how you're doing in Genesis with monoclonal antibody therapy. So I know it wasn't on the agenda, but that was a phone call from our chief medical officer at Hopkins this morning. So share with me your experience. Has anyone had the opportunity, has a positive SNF patient, resident, and thought about it? I know you have at Genesis, so help me out here. And don't forget to unmute your microphone. Adam, you have no monoclonal antibody use in Pennsylvania? I'm putting you on the spot.
Well, I would defer to them on that. I don't necessarily have the data on how many patients we have. Troy's unmuted. I'm not sure if he's gonna.
Yeah, I was trying to get back to, I was trying to unmute myself.
Okay.
Sorry.
We've had a few. We've had at least 4 or 5 that we've done already so far. All seem to be very good. It was run through Penn Infusion. Very simple process as far as everything that we've been working through, as far as getting the referrals set off, getting the information, getting them out. They're very professional. They do it. They're with the residents. They infuse them. About an hour later, they stay with them, and we've actually had a lot of success cases with it. Nothing that other than it has really actually helped to, I guess, do what it's supposed to do. I'm not a nurse, but I would say that from what I hear, the residents are recovering rather quickly, and they seem to be benefiting from that therapy.
Great, thank you. And the Penn Infusion, is that a home infusion program that
It is.
runs through Penn's health system?
Yeah.
And their pharmacy had the therapy, or did you use your long-term care pharmacy?
We had used their pharmacy. They actually were able to dispense it, and that was one of the things that was it was very time sensitive, because once it was actually drawn up, and then it was to get it to the facility and really get it into the residents as soon as they could.
And you use their infusion service, so their nurse as well?
Yeah, that's who we used.
And in terms of barriers for that, in terms of financing all that, any barriers there?
That was part of the CARES Act. That was, part of that. Now, maybe moving forward, it might be a little bit more difficult as the money's kind of dried up a little bit. But from that perspective, no, that was all taken care of.
Great. And let me ask you if we're advocating at a state and national level that long-term care pharmacies begin to have access and stock it, just like we get our flu vaccines that way. Ultimately, we hope that the COVID vaccines will be that source of distribution for us long-term, not just these stand-up clinics right now. What are your thoughts in that approach as we're advocating for that approach on a higher level?
I believe that's the direction everything's moving towards. We haven't had the experience to use it that way. We've only gone through the Penn side of things, but I do believe that's where things are moving. I think having that as in the physician's toolkit, and also from our perspective, because we do have the positive COVID unit, so when we're admitting patients from other facilities, we're able to just kind of do that as in conclusion with everything. So it's just something I think it's going to help to speed things along. And also with the increased clinical capabilities of what we do with it, it just is another little notch for us, what we do.
Good. Do you feel that your medical providers have enough knowledge in using it?
Yeah, actually, we have a couple of nurse practitioners that are here full time. We're very well versed in it, and then our medical director actually is very involved. So when this became available, I think we were clawing at Penn to get this going. I think they wanted to start slow, and we were one of them that was, we were like, we have 3. So it was something that it was embraced from the get-go.
Fantastic. How about your nursing education? So the infusion group was bringing in their nurses, but I'm sure you did some education for your staff, nurses,
Yeah,
assistants?
100%. You know, there was our nurse practice educator, IP specialist, actually did education with the nurses on those specific units to ensure that we were doing everything that we could to, but like I said, the nice thing is it was a one-stop shop through Penn Infusion. You know, they sent their nurses out, they sent the medication out, basically all they looked at from us was, hey, where should we throw this PPE away? And they kind of took it from there. So that was what made it very easy for us.
Yeah. Wow, we've come a long way from the days where hospitals were silos and nursing facilities, but this type of partnership from a health system uh, is a wonderful response, and why we'll begin to see better outcomes, or we're already beginning to see better outcomes in terms of morbidity and mortality, and then ultimately, as we have lower cases, begin to get back to business as usual, right?
Yeah.
Yeah, great. Michael from Brandywine, you've had some experience too. Can you unmute?
Yes, we've had some experiences as well, and all been pleasant. It's very quick. Usually, sometimes the same day, or definitely within 24 hours, that they're able to come down and do the infusion. And they've even been nice enough to leave the pumps for us.
Wow. You're not going to see that very long, right?
Or actually, the poles. Let me rephrase that: the poles, not the pumps.
Okay.
The poles.
Because they're expecting to come back, right?
Yes.
Yeah, that's terrific. That's wonderful feedback. And again, I think it makes us all, we've got more tools in our toolkit to manage COVID. So that's fantastic.
If I had a dime for every time I got a letter that I needed to return a pump, I would be rich right now.
There you go. A new source of
Omnicare. So Omnicare, to Troy's point, they are moving towards, having better access to BAM, if you will. I think the last update, there was only like less than 450,000 doses that were administered in the country.
Yeah.
So, that's been one challenge. And also the fact that the vaccine rollout happened at the same time, to push for the antibodies. So that's one challenge too, because it affects, their ability to receive the vaccine and all that. So I think that's complicated some of the push for it as well.
It reminds me of, I can't remember how many years ago now, when we first had Tamiflu available for influenza and how we couldn't get our hands on it initially and wanted it. And the folks for whom we wanted it the most were our nursing home residents who experienced flu. And now it's, widely available, right? So looking forward to that approach, recognizing there are also some wonderful research going on. And in fact, one of the researchers here at Hopkins who's doing some oral therapies for COVID management and looking for recruiting volunteers. These are currently in some phase 2 trials rather than phase 3. Phase 3 is the large scale clinical trials where you enroll thousands of people. These are the smaller trials, but they are trials of individuals with COVID, active COVID infection. So it's coming. There's intranasal therapies as well as oral therapies, because ultimately then we don't have to worry about infusion centers and registered nursing availability, and certainly storage will be easier for our long-term care pharmacies. So it's coming, and COVID will become like influenza, not in January of 2021, but maybe as early as January of 2022 for all of us. But let's wait and see, right? Any other comments on the monoclonal antibody as our first therapy in our skilled nursing facilities and assisted living to treat COVID? If not, I'm going to share my screen again. And this time, I'm going to continue on with the PowerPoint presentation I prepared. And I wanted to highlight, as we're all in the throes of vaccinating staff and residents, some wonderful literature to look at for strategies to improve our staff and resident confidence in vaccine. And in a call I had earlier today with a national assisted living program, discussions about how that the first wave of staff vaccinations ranged with 40 to 60% staff acceptance, and often 80 to 90% acceptance for long stay residents. But hearing staff who were not vaccinated with the first wave interested in the outcomes of their colleagues who were the first wave, and considering that second wave. And as we begin to have second opportunities with CVS and Walgreens, and ultimately to have the vaccine the way we have flu vaccine, strategies to get those staff members with increased confidence. So this is the American Medical Directors Association. It's on their website, a list of ideas. And many of these ideas, I believe you're all already doing. But just wanted to share these with you. Having the town halls with staff for questions and answers, following up with posters and flyers so that they're also a visual reminder of key points with the vaccine, and even having staff developing these posters and flyers. And I've now seen two versions of long sleeve and short sleeve t-shirts that facilities and corporations have developed that are given to those who are vaccinated. And you know, they're a powerful reminder that people speak, and many staff who have been vaccinated are role models for other staff, and getting that visual reminder out there. So I just wanted to share these, and you probably are looking at these on your screen and checking off each one that you've already done them. But I want to stop sharing my screen for a minute and just hearing from all of you how your vaccinations have been going, particularly for staff. I think we're all finding resident and family member acceptance to be much higher, although if you're not, let's hear about that. But I'd like to get some update on staff vaccination acceptance. Any facilities planning for their next round or want to share your first round data for staff acceptance and resident acceptance of vaccine?
Sure, this is Matt from Hopkins. So for the first round of vaccine for us, we were December 30th, so we were kind of early on. Staff acceptance was about 50% or so. We're having our second clinic next Wednesday, and we've gotten it up to about 80%. So that's a good, jump. It's just a lot of people wanted to see what was happening, and a lot of the misinformation we were kind of able to dispel by having a lot of conversations with them. And residents were in the 90s. So it just needed more time, I think, for the staff for us to really get out there and reach them, and for them to, sort out the truth from fiction.
Matt, can you share with us what you did in the facility between the first round and the second round?
Sure. We met with, all staff, individually. The people that declined it the first time, we met with them individually. The first time we just did, large kind of group settings. And then the second time we had a little bit more time, actually. So we were able to meet with staff individually. Our medical director was very involved with, talking to them and dispelling those kind of myths and rumors. And that's kind of what turned the tide, is really meeting with them one-to-one.
Great. Yep. That setting the example first and giving those who are unsure the opportunity to observe what's happening in the first wave. I think we're all finding is a very good strategy. The huddles where it's discussed. So that's great. And thank you. We have some chat comments. Linda Sullivan reported unable to use her microphone, but in the first round yesterday, several staff members who initially refused then consented when they were observing the others getting their vaccine. Jessica Copa mentioned 93% for the residents for the first. So I think we're all finding that the residents, and particularly their family members are encouraging the residents and accepting vaccine. I think that's also having some impact on our staff as well, seeing that community response. Also, the news media right now reporting on all the state approaches and challenges of people wanting the vaccine who can't get it yet in the community. It's like, wow, if they want it, maybe and I'm lucky enough to have access, maybe I should. So thank you. Let's see here. I think, and Jessica Copa also mentioned that two staff got the vaccine with the second clinic that didn't, when the first group was getting their second vaccines, they joined in and got their first vaccine. So we're all beginning to see this second wave approach. And anyone else want to talk about strategies from the first group of vaccines to the second? Any other thoughts on how we do that? And I know within my own floor, individuals are talking it up. People are coming back from their vaccines saying, just got my vaccine. And just, when you walk by and say, hi, how you doing? It's like, got my vaccine today. And others are in the area observing that. And of course, my response is always fantastic. So glad you were able to do so. Can't wait till we all have. Just walking by saying that, I know there are others who are hearing that, who are thinking, what am I missing out on? Now, I will also share with you that we are into our second round of vaccines pretty routinely, since we were some of the first in the state of Maryland to get vaccinated. We are seeing particularly young women with fevers in the second vaccine, where they only had some mild local irritation. They're low-grade fevers, but they're real fevers. They know they have a fever. And our staff in general understand that and take their acetaminophen, but it is a challenge for staffing because we all have the protocols that fever means you cannot work for 24 hours. And so we all have our backup schedules now, and we don't have the luxury, most of us, of trying to schedule around, when the vaccine's available, we take it, right? But recognizing one challenge in vaccinating this population will be that some by protocol will be missing their shifts, but it hopefully will be a small number, but nonetheless, we are seeing it. And when we see it, nobody gets upset. We just say that we knew this was going to happen, and we are doing our best to maintain staffing. Has anyone, I think some of the groups are into their second round of vaccine. Has anyone experienced that within your facility? Am I right that some folks are in the second clinic? Or maybe they're about to have the second clinic. I guess, Jessica, you mentioned the second clinic will be Monday for you. So, so when that second clinic happens, you may, if individuals are getting their second dose, the estimate is a low number. It's less than 10%, maybe around 5%, but you've got 100 staff. You may well have 5 individuals with a fever. And if they were all scheduled for the same shift, are we all prepared for that? All right. So we talk about the successes, and then we talk about some of our challenges, and sometimes just knowing that the challenge is there and being prepared is helpful to us as we plan our strategies. And certainly there will be that individual who has that reaction that might then sway someone else from getting that vaccine. But in general, those who have had a fever for 24 hours and then back to their usual, we encourage them to say, you know what, it was a fever for 24 hours and move on. So, okay. Let me share my screen again. And let's go to, want to go now to the quality improvement portion of today's session. And it's the improvements in 5 steps where we identify a problem, where we observe it. We in our small groups, particularly our huddles, chat about it, get ideas about the magnitude of the problem. You know, for us with COVID, is it early on it was PPE and educating on how to use PPE where we never used it before. How do we, and now I think the big chats are, how do we prevent staff to staff spread by social distancing in our break rooms? Then we begin to map our strategies, and then we begin to measure them. And measuring, when it comes to staff spread and staff to resident spread, it's the actual data on positives as we do our scheduled surveillance. And then we share those data. So the 5 steps are understanding the problem by observing it, talking about it, and then setting a goal. What are we trying to achieve? How are we going to do so in step 3? And then doing a small scale testing. Maybe it's a pilot of a few days, maybe it's a few individuals, and then measuring your impact and then sharing and disseminating those data. Let me stop sharing that. And let me also now go to, with this information, I want to get to the actual diagram for this session 7. So let me pull that up, sorry. And this PowerPoint is on our IHI website. And I want to highlight particularly the use of high-level flow charts for design of these as we're trying to set up a program. Maybe the program will be on COVID infection management with monoclonal antibodies, but using high-level diagrams to do so. And let me just flip through here. Here are some examples of using, here are 5 different examples that are COVID related. And the first step with the process to improve is clearly stating in a few words, what is it you want to improve? And here again, 5 examples: proper PPE use. Staff burnout is a topic we'll review in a future session, but is that your process you want to improve? Cohorting is another. Testing, we've certainly been doing that testing. And then certainly the visitations are an area that we'll hopefully in the future get back to improving. So here's an example for PPE use and the other for screening. This is the take-home message for this week, using these high-level charts and basically having a few bullet points visible for those who are involved in this process improvement to respond to. So for example, here for obtaining PPE, here are 5 key bullets: who's responsible, where's the equipment stored, who's doing the inventory and when, how are we verifying the supply, and what are the action plans when we don't have the supply we need. So basically in a visual format, the key information regarding this process that one wants to improve. Here's another example. This one's in proper PPE use. So what are the key bullets for proper PPE use?
Are you sharing the screen? I'm sorry, Michelle.
I'm sorry to interrupt you, Michelle. I think you're not
We don't
sharing
see
the
anything
screen.
on the screen.
Oh, thank you. Oh, goodness. Okay.
Yeah.
Well, I certainly do, and I would just keep talking, so thank you.
You're welcome.
Let me get back here. I missed that key step there in my excitement of what we were doing. Okay, let me get back to the right session here. Okay, can you see it now? My screen.
Yes.
Yeah.
Okay, thank you. All righty. So this is what I'm talking about, high-level flow charts, and these were the examples from COVID that I just mentioned. And here's a visual for the first one, obtaining PPE, where you just mark out the key steps in a visual way. And here's the proper PPE use, was where I left off with. And what are the key elements of a quality improvement project for proper PPE use? And and this is one we actually did ourselves on my unit this week. And that's because we had a staff member who we've determined through contract tracing spread COVID to 3 of our inpatients, our long stay inpatients in our post-acute unit, and 2 staff members. We've determined that improper use of PPE for an individual who was mildly symptomatic led to the spread. So we've done this type of flow diagram in our unit. And we said, you know what, we have all the PPE we need. We need to re-educate on using the PPE and appropriate, and particularly what we found, not only proper PPE use, then we found social distancing in our break rooms. And we determined that indeed the individual who spread the COVID had lunch, had breaks with the 2 staff who became positive, and it was clear that there wasn't social distancing. And these data, or this information we achieved by small group huddles where people shared, you know, how do you think this happened? And individuals said, you know what, we didn't realize that individuals who are mildly symptomatic or not symptomatic can spread it, and we just love our time together at lunch. And so as a result, we now have individuals signing up on a sheet for their time for lunch. And we put some music in the lunchroom and ways to de-stress, but it's de-stressing with social distancing in a way we had to double down since we had this own experience in our own unit. But using flow diagrams to help visually see the impact of a quality improvement project is the take-home message here for today's. So each of the boxes gives a process, but keeping the number of boxes to 4 to 5, I think, is another take-home message here. So it's got to be a simple diagram. Complexity leads to inadequate response. So, and I want to share with you this final little diagram that's on our IHI website for our Project COVID in the nursing home educational materials, and particularly for session 7. This is the QI information on how to do using high-level flow charts in your process improvement. I'm going to ask Victor Boguslavsky, who is our IHI expert on our sessions every week, to share his insights in using high-level flow charts and this type of quality improvement process.
Thank you, Michelle. Well, first of all, beautifully described. Thank you. You know, and great that, you know, we have the 5 steps, and following from the last session, we had, you know, 5 improvements in 5 steps. And I think that is pretty much self-explanatory, but I think the purpose of this, again, a higher level flow chart, not to start for the teams to go into the flow charting of the processes in details, but rather to look where the problems were or are, and then help them to unpack each of the step, which is a sort of less time consuming and resource consuming sort of approach that helps you to understand better what kind of processes you think would require improvement from your point of view. And so it's a very helpful sort of logical sort of type of thinking for anyone who wants to unpack the processes within the within this whole care continuum sort of larger process in the facility. But again, thank you so much for walking through the high level flow chart and those guiding questions. Perhaps I just wanted to, since we're on the vaccine note, maybe just for everybody to, again, to take a look at the special vaccines session materials that are at the IHI library. And there is a good presentation there. I think I would suggest to look, although it seems like everyone is doing great, and excellent examples about moving from 50% to 80% coverage. That's a great learning. You know, would love to have more details about it. How did you manage to get from there to there? And what type of change ideas you tested, and how did you measure those? But that's a kind of presentation that helps you to think through the design of your improvement activity for the vaccination. So I really suggest you to take a look at these steps, and, you know, helps you logically walk you through.
Great. Thank you, Victor. Yes, the IHI website that's open to everybody here. It's just a great place for resources. That's where I pulled the AMDA vaccine checklist from as well. So very important. Good.
Wonderful, thank you.
Good. Next week's session is on staff recovery from COVID. So I will ask the group, the homework assignment here is for the folks on this call, if you are aware of a staff member who's COVID recovered, to take a moment and ask them about their experience and ask them in looking back, how might the facility leadership and their colleagues in the facility have helped them more in their recovery. So like to have some case examples next week from your facilities in staff who've recovered and returned to work. And there are some staff who may not have returned, but share your experiences, because I think this is going to be a very important, our workforce is a critical issue for all of us. And for those who have recovered, we need to support them and figure out how we can best support them. Okay. Any last comments as we finish up for this morning? And anything from a corporate level, Adam, if you're still on before I close off the session? Hearing none, I'll wish everybody a wonderful day and a safe day, and we'll see you all next Thursday at 11. Take care.
Thank you.
Bye-bye now.
Bye-bye.